Over to Dr. Trupti. So she's gonna discuss one more case regarding alarm bell situation in a anterior capsular or a posterior capsular surgical scenario.
Thank you, Dr. Tushe. Now I'll be showcasing posterior polar cataracts. Posterior polar cataracts is a scary situation for most of the phaco surgeons, more so when we can...
Can you put the video on? The video for, yeah, done.
Yeah. Posterior polar cataract is a scary situation for most phaco surgeon, and more so when we can see a pre-existing posterior capsular defect. Here we have a 41 years old lady with a posterior polar cataract, and we can see a pre-existing defect in the posterior capsule. The cataract is very soft, NS1 type, and the patient has high expectations. When we do the anterior segment OCT, here we can see a moth-eaten appearance, which will indicate that the PC is dehiscent, and there is 99% chance of a posterior capsule rupture when such a finding is noted. On the slit lamp examination also we can see clearly that there is an onion whorl appearance of the cataract, and we can, if we see clearly, we can see two lines in front of and beneath the onion whorl, which indicates that the PC is dehiscent or the PC tear is there. Now, what is the surgical plan in this case? The main thing which is going to extend the posterior capsular tear, or which is going to push the nucleus into the vitreous cavity while doing the phaco, is the change in the intraocular pressure or change in the if the AC collapses. So what we have to keep in mind is that while operating a case of PPC, the chamber should remain stable during each step of surgery. And while we come out and go to the second step also, we have to be sure that the chamber is formed. So we are going to use stable chamber settings. We are going to use the lower IOP settings, which will be varying between 20 to 28 millimeters of mercury. The site of incision. How do we plan the site of incision? We have to take a look at the direction of the tear. Here, when the direction is diagonal, our site of incision should be 90 degrees to the site of the axis of the tear. In PPC, hydro procedures should not be done. No hydro procedures will be doing. We will not be rotating the nucleus, because anything, a fluid going inside will cause increase in the PC rupture, or if we rotate the nucleus also, that much movement will cause the nucleus to dip down. And we are going to use mechanical separation or visco separation if required, and we are going to do the dry aspiration of the cortex. This is what we have in mind when this surgery is planned, and a IOL capture can be done. How to plan the rhexis in this case, because this is the major step which is going to help us do a good phacoemulsification as well as place the IOL. In this case, we did a oval rhexis. Now, what is the advantage of an oval rhexis? Oval rhexis gives us the best of both worlds. That is, it gives us the advantage of a small rhexis as well as it gives us the advantage of the larger rhexis, because in one axis it will be smaller in size, whereas 90 degrees apart where it is oval, the rhexis will be larger in size. The larger rhexis will give us the advantage of no rise in the intraocular pressure. We can do a safe end-to-end sculpting, easy division of the nucleus, and also it becomes easy to remove the subincisional cortex, and the IOL entry can be very smooth. Whereas the smaller rhexis gives us an advantage of the optic capture, and the nuclear fragments will remain in the bag, and if any vitreous, if it is coming, the smaller rhexis will give a tamponade to the vitreous. So by using a oval rhexis, we can have the best of both worlds. We can have a large rhexis advantage as well as the small rhexis advantage. Now the cases begin. We can see that it is a very soft cataract. We can visualize the tear also, which is there pre-existent. And being a very soft cataract, after doing a trenching, it is not possible to separate the nucleus. And now we are in a no man's land, what to do? Because PCR is already there, the nucleus is not separated, what to do? What we have done is, you can see that in the inlay, the IOP settings have been lowered down. The IOP is 30 right now, and we are trying to remove the nuclear fragments by mechanically separating them and then aspirating. At this setting, you can see that in spite of having a end-to-end PCR, pre-existing PCR, the nuclear fragment is just floating where it is, and it is not dipping posteriorly as one would have expected. Now visco is again introduced before taking out the probe, and to separate the remaining nuclear matter, visco dissection is done. Viscoelastic is introduced on two sides. Even subincisionally also we have introduced visco using a J cannula. Now this nuclear material is remaining floating in the AC. We have further lowered down the settings to 20 millimeters of mercury. Centurion machine is being used, and here we can see that at these IOP settings, 20 millimeters of mercury, the nucleus is easily emulsified. It is remaining just in front of the probe where it is not going posteriorly. No vitreous is seen, or the pupil, there is no change in the size of the pupil which may indicate that vitreous is coming in the anterior chamber, nor there is any deepening of the anterior chamber which may cause extension of the tear. Now the nuclear material is emulsified and only the cortical matter is remaining. Because there is a large tear, it is decided that dry aspiration of this cortex is to be done. We use a 25 gauge cannula, just slightly irrigate at the point where the cortical matter is there, tease the cortex, and then slightly by a tangential stripping, the cortex is removed from that area. It is not aspirated into the cannula, but it is slightly stripped off and taken away, and then removed with visco. Now staining is done with triamcinolone acetate to see whether there is any vitreous in the anterior chamber. No vitreous is seen, and we have decided to put the multi-piece intraocular lens in the sulcus, which could be put easily, and an optic capture is done. So even in a case of posterior polar cataract with a pre-existing tear, phacoemulsification could be done safely without extending the tear, without causing any posterior dislocation of the fragments. The patient had a very good visual outcome of 2020.
Thank you so much, ma'am, for enlightening us with the posterior polar cataract.
Yeah, one has to be very careful about the post-operative follow-up, because sometimes we tend to miss any fragments which may be dislocated posteriorly. So close watch on the inflammation, and the VR consultation is mandated.